Hello, everybody, and welcome to our first Care Steps training module. This is Module 1, the Purpose, History, and Accountability of Care Steps. Now, as part of the onboarding process, this usually would have been done in person during a site visit, but given current circumstances, we are having Charles join us and doing these via 3 different training modules that will be available online just as a webinar format. And this will be the first one that's available to everybody on your health center teams. We'll be covering an APCM, just general overview. Charles will be talking about some visioning. We'll be looking at the accountability plan, looking at the actual categories and buckets of care steps, their history and evolution, and I will take on the discussion of the non-engaged patient closure process. And we'll finish by looking positively on what makes care steps so unique and exciting. The first thing I wanted to do is introduce Charles. He was the first APCM manager OPCA. He now works at Virginia Garcia Memorial Health Center as the clinic manager of the Hillsborough site. Charles, would you like to introduce yourself?
It's so great to be back with OPCA for this project. Like Amy said, I'm now with Virginia Garcia, work at our Hillsborough campus, which includes both primary care as well as our OB clinic. I've been there for about a couple of years, and it's been really exciting to see how kind of policy, payment, and care is connecting, to the ground level. And happy to be back with OPCA for this presentation.
Thanks, Charles. We're so thrilled to have you because you have such a unique perspective of both the APCM mechanics and also the view you have of the health side, the actual care side that you engage in every day. So we are very happy to have you on board. Charles will be presenting on all 3 of these modules, I am Amy Vassarino. I'm pretty sure that everyone who will be viewing this is familiar with me, but I am the current APM manager. Second only to Charles. Together we make up all of the APCM managers at OPCA. Have been with OPCA for 8.5 years and have been the manager of this program for about 3 now, maybe 2. Edit. Manager for about 2.5 years now. All right, so let's get started. Let's do just a quick overview first of APCM in case there are health center staff members who were not part of the onboarding process the last few months. What is APCM? So basically, I tried to boil it down to just this one slide. Instead of being paid fee for service for primary care visits, clinics are paid a capitated per patient per month rate for their active patients. And this is, of course, the wraparound from the state that we're talking about. Each rate is unique. It's clinic specific and based on historical utilization and revenue data. And the hope is that by being paid prospectively monthly, clinics will be able to transform their care away from that traditional office visit and be more flexible and offer a wider array of services to their patient population. This was OPCA's goal at the beginning of this program, and I won't read it aloud. Really, we're looking just to make sure that we're offering a payment model that mirrors what care the health centers want to offer. And we have been using the quadruple aim as our format for our accountability plan since the very beginning. That's quality, access, cost, and our 4th aim is population health equity. Charles, do you want talking about visioning?
Yes, very happy to. So just some background. So Virginia Garcia was part of the phase 1 group, and I think through that cohort we learned that care change doesn't just happen by changing payment alone. It really takes leaders and teams to pause and really clarify what their North Star is. What is it that they're actually trying to achieve under changing payment? So this is something that OPCA has tried to facilitate with every new phase. This idea of visioning and figuring out your North Star. And it's something I highly encourage you to do now that you're going to start getting paid this way. I'd love to be with you in person, do that visioning, but this pandemic had other things in mind. So, so with that, I want to just give you some thoughts to partake as you undergo visioning. So the 5 strategies under APCM, I take it that you've seen this in the past through OPCA. I think of these as change concepts. Once you are under this payment methodology, what are the things that you are able or willing to change as it pertains to the way you look at data, as it pertains to the way you want to build your care teams? What kind of changes could you make? Is this a possibility for you to add on expanded members of the care team, such as a clinical pharmacist, such as a CHW? Appropriate care, what are the different ways that you can help patients navigate the health system more appropriately? How can you help kind of divert their needs away from the hospital into primary care? Partnership, this doesn't just entail community partners, but the new ways you can partner with patients that can lead to co-designing different models of care. Of course, access is a big part of this. Now that you're getting paid under capitation, what are the different ways you can expand access to not just be a face-to-face delivery model, but different modes of access that touch on telehealth, that touch on remote patient monitoring, that touch on group visits and other types of care team members. So really, I'd look at these, I not only reflect on them, but actually list out some of the different ways you want to change, change under these 5 strategies. And I do some project chartering under it. Think about goals for year 1, maybe what your North Star is for 5 years, and then work backwards from that. And then, in addition to ways you're going to change your care model, this is also an opportunity to think even more expansively. And as this social determinants of health visual appears, this isn't just about what we do in the clinic, but this is also an opportunity to think about you're going to go outside of the clinic walls, to work more to make sure that upstream changes are occurring within our patients and the populations we serve. So this is an exciting time for you. I'm really excited. Virginia Garcia has been doing this for many years now, and we're still undergoing this journey of change and thinking more upstreamly about how we want to care for our patients because of APCM. Next slide. So speaking more specifically about population health approaches we're taking at Virginia Garcia, APCM has really allowed us to expand our primary care teams to include those roles I just mentioned, really integrate our behaviorists into the model of care so that it's not just kind of this add-on feature, but someone that's truly part of the team anytime a patient comes to see their provider. We're really thinking more strategically about population-tailored programs. So it's not just a one care team fits all model, but one that could be redesigned to meet specific populations, like pediatrics, populations that are more in need of social work, case management work. Transitions of care programs are a big part of it as well. And then thinking of innovations like social determinants of health interventions. So if you are, when you embark on social determinants of health screenings, what's the intervention that's going to be on the tail end of that? Also needing to think about new forms of access and care like we just talked about. And this is also an opportunity to drill down into special populations you want to start thinking more strategically about how you want to serve them. So those are some examples of how we're continuing a vision under the APCM model. But in addition to that, you're also going to need to start building some infrastructure. So the next slide will show you some capabilities that are needed for value-based payment models. So it's not just around, of course, it's also about visioning and coming up with the changes you want to make to your care model, but it's about investing in data and infrastructure, knowing how you're going to track and your quality and access metrics, getting total cost of care data and figuring out how you want to respond to it, coming up with a way to look at, to not only receive and send data, but to have some analytics around it, and getting your finance department involved in helping you evaluate return on investment and additional VBP opportunities. So that's those are some tidbits for visioning. Again, really excited about hearing what vision you have for your APCM model, and excited to hopefully one day see you in person and talk about it more. Just talk about it more.
Thanks, Charles. All right, let's take a closer look at the accountability plan. Like I mentioned before, it is based around the quadruple aim. You can see that care steps fit into the axis, so the bottom left quadrant, the blue one. Clinics report care steps data quarterly. OHA will remove patients from clinics' APCM list if they have not received a visit or care step within 8 quarters. That refers to the non-engaged patient closure policy, which we'll be talking about later on this call. But first, let's focus on the access quadrant. I should mention that STEPS is an acronym. We have a lot of them in APCM. This one stands for Services That Engage Patients. Things you should know about care steps. They are unique to Oregon's APCM program. They were developed for this program in particular, and they have become actually quite renowned now. We'll talk about that at the end. Since they are sort of cutting edge and unique, they do come up quite often in calls nationwide. And then they try to focus on meaningful two-way interactions with patients. Charles will talk a little bit about how we arrived at these 18 from a longer list of 32, but the point was that these categories focus on the interactions that actually engage patients. That's part of the acronym, and have a two-way component. So it's not just, for example, a one-way phone message. That would not be meaningful. Another thing to know about care steps is that they are one of the main ways to keep patients on your APCM list and paid for, along with visits. And for those OCHIN health centers, it's important to know that they are still called touches, as you'll need that information when you go to document them. So let's take a closer look at the care steps and buckets. There are 18 categories in 4 buckets. Charles was the one to first put them into these 4 buckets, and I'm hoping he'll say a few words about how he did that.
You're totally right, I did. I forgot about that.
Yes, we always give you credit, Charles, when we talk about the bucketing. So you can see that there are new visit types, coordination and integration, education, wellness, and health promotion, and reducing barriers to health. Charles, is there anything you want to mention at this point?
So these, I wouldn't look at these buckets as like mutually exclusive categories. There's a lot of overlap between them. A lot of these care steps kind of could occur in succession. Many of them could occur in lieu of others or in lieu of office visits. We just felt like these were like 4 distinct ways that where we see you doing existing, innovative, high value work, and in addition to opportunities to expand on the work you're doing.
Great, thanks, Charles. And we'll be going into these more in depth on our next call that focuses on documenting and delivering them and designing them. So more to come on the care step categories. All right, let's look backward a little and see where these came from and why. And I'll actually hand it to Charles.
Yes, so in the beginning, they were called touches, as Amy alluded to. And that initial list, as we were trying to figure out where this care model was going, we decided to be more inclusive than exclusive. So we captured a lot of the amazing work that FQHCs have been doing up until this point. A lot of that work tied to PCPCH, the primary care renewal effort we had going on in the 2000s. And with that, continue to keep those future-leaning care team innovation buckets that are on today's list. Back then, care steps didn't always occur in lieu of office visits. You were just getting a credit for any care step you provided, whether or not an office visit occurred. So we at that point, we were just primarily concerned with capturing a big chunk of all the non-billable care team activity, if not all of it, really. In the beginning, during phases 1 and 2, care steps were often analyzed in aggregate because we weren't able to parse out those that happened in lieu of office visits. Those reports were also accompanied by narratives that helped explain any gaps that occur between APM payments and the PPS equivalency, which you'll start seeing on your quarterly reconciliation reports. So it was mainly for high-level analytic purposes, and it wasn't really something we thought of in a mechanical format the way we do now. There were 32 categories, as mentioned, and in order to really tie it to per patient payment, we decided to trim it down to 18 categories that were really future-leaning, that we felt like were innovative, and that we knew could occur in lieu of office visits, so that we could isolate those non-billable care team activities. So that's what it was like in the beginning.
Thanks, Charles. We've come a long way, and yes, in 7 years. Okay, I want to take a few minutes and talk about the non-engaged patient closure process, since that is one of the main accountabilities that you're going to have under APCM, and they directly relate to care steps. Here are the basics. This is how it's going to work, but only after you've been on APCM for 8 full quarters. This is how the process generally works. OHA is the one to create a list of patients who haven't received a visit, and that can be billable or non-billable or a care step within an 8-quarter look-back period. And that report is called the Non-Engaged Closure Report, the NACR for short, another acronym. Once health centers receive those reports, they do have the opportunity to appeal the patients included on them. And then if it turns out that that patient should have been removed, payment recoupments will be taken back to the beginning of that quarter, that reporting quarter for closed patients, and taken out of the next big monthly PMPM payments. And of course, if that patient does end up coming back to the health centers have the opportunity to reestablish that patient just like anybody else. So that's how it works in general. It has been a little bit tricky to implement. We did start the process back in Q2 2019 and then officially paused it back in Q4 2019. So we had about a full quarter of implementation before the pause. This was because that there were unforeseen challenges within the MMIS system and a large amount of appeals, since this first implementation period would have looked all the way back to the beginning of the program for patients who did not have a care step visit within 8 quarters. So some of those lists of appeals were quite large and difficult for OHA to keep up with, which is understandable. We are tentatively looking ahead to Q2 2021 to restart implementation. This is very tentative still, based on what's happening with the pandemic and where health centers are at, to be honest. And of course, since phase 8 is just entering now, this is not going to be implemented until Q4 2022, which would be 8 full quarters on the program. So we're looking pretty far in the future right now. All right, let's finish though by looking at what makes care steps so unique and exciting. And I will go first and then turn it over to Charles. I would say that like I mentioned at the beginning of this call, when people contact me with questions regarding our APCM, it is often about CareSteps because they are so unique and innovative when it comes to actually gauging what's happening between patients and health centers on the ground in lieu of these usual traditional office visits. When we met with Lori Coiner, who's the Medicaid director, back in the end of last year, the one thing that she actually had heard about and actually was really excited about, what were the CareSteps? She was the one to bring them up before we did, which was very exciting. And I would say that the incentives are in the right place in that it really motivates health centers to maintain that close engagement with their patients, even if they are not bringing them in for traditional visits. They are still meant to be, maintaining those relationships and providing care in the way that makes sense for patients. All right, Charles, what do you think? Why are CareSteps so exciting?
Well, everything you just said. I am biased. I do think they're awesome. But when I was reflecting on this question, what makes CareSteps exciting? These are the points I thought of. It removes the face-to-face middle person or middleman, as you can say, from that patient and care team relationship. So with CareSteps, care team members can go directly to patients and not need to worry about funneling it through a face-to-face encounter for it to count. The 18 categories, I see them as each one of them as an open invitation to continuously think outside of the box when trying to mobilize your care team to focus on specific populations or just your entire population. There's a whole array of options for you to consider, and it doesn't have to go through the provider anymore. So this third point is something I really came to appreciate when I moved to Virginia Garcia. A lot of exciting, novel, care innovations usually occurs because of a grant. CareSteps allows you to include that stuff as part of your regular operating model. You don't need grant funding anymore. You are getting paid to do this cool, exciting work. Now I see grant funding more as a runway to figure out how to include it in your operating model. But I don't see it as a necessity to include it anymore. I also think CareSteps gives you a whole array of amazing data that you can correlate with your outcomes data, with your cost data, when figuring out an ROI for any program that you're monitoring or trying to ramp up. I also want to add, sorry, I'm trying to segue as we go to the next slide.
Yeah, I'm trying. Sorry, it's stuck.
Okay. To close, I really see CareSteps as a way to help narrow any disparities that are happening between the populations you serve. So what you see in front of you, to the left is our trend lines, and these are the percentage of patients with A1Cs greater than 9 over the last year. The blue line represents our Hispanic patients, while the orange line represents our non-Hispanic patients. And I think any one of us with experience in this field can easily say, well, those are structural elements in play. This is where the social determinants of health come into play, in that non-Hispanic patients are probably more likely to live in places with greater resources, regardless of poverty level. What's exciting or more interesting to me is the graph to the right, or my right, and maybe to your left. And this is the A1C evolution over a patient's visit. So these are two different populations receiving the exact same service at our site in Virginia Garcia. Once the A1C control process was established with a non-Hispanic patient, you start seeing the drop. Actually, quite the opposite happened with the Hispanic patient. You actually started to see it creep up a bit. So this is something we're still trying to figure out a health system. Even within our walls, how are we tailoring care differently for our populations? And I really see CareSteps as a leverage point here. Maybe those Hispanic patients need a different kind of interaction. maybe it isn't the kind of the face-to-face visit with a provider that's helping them, but maybe it's more of a group visit with other Latinos. Or maybe it's more intervention with their CHW to make sure that they're getting connected to the right resources, whether it be food, whether it be housing. So that's what excites me about CareSteps. It's not only a menu of access options and everything else we talked about. It's really a tool to help you address disparities within the populations you're serving yourself.
Thanks, Charles, and thanks everybody. That concludes our first module, which is meant to just be sort of an overview of accountability and what CareSteps are. Our next two will focus more on the delivery, design, and documenting of them, and then finally data and QI and what you can do with APCM data. So thanks everyone. We will see you on either the second or third modules.
Bye everyone. See you soon.